It's Wednesday, January 20th, we're starting a little late. It's about 1:53 p.m. Madam Secretary, let's establish a quorum. Please call the roll.
Senators Cannella? Here. Cannella here. Leyva? Leyva here. Mitchell? Mitchell here. Runner? Here. Runner here. DeLeon?
Here.
DeLeon here.
We've established a quorum. First and foremost, I want to my left, I want to welcome our new Vice Chair, the Senate Rules Committee, Mrs. Runner. Senator Runner, thank you very much for agreeing to be a member of this Senate Rules Committee, and we welcome you to the Senate Rules Committee, so we want to thank you very much.
Great to be here. I look forward to it.
Fantastic, fantastic. Ms. Mitchell, Mr. Cannella, as well as Ms. Leyva, welcome again. Colleagues, we do have a little ambitious agenda here before us today. We have file item number 1. We're going to take this out of order. She is B. That is Jennifer Kent, Ms. Jennifer Kent, who is here for the position of Director of the Healthcare Services Department. Mrs. Kent, welcome. Good afternoon.
Good afternoon.
Why don't we start off, if you could be so kind enough, just anyone you want to introduce, any immediate family members,
Sure.
loved ones, please feel free, and we'll start off with your introduction, and then we'll go to Q&A.
Great. First, I have my mother. Susan Morton is in the back corner. So without all that, that would not be possible. My brother and his wife, Julie, who are sitting next to them. And again, I, tormented him through a good 40 years of my life. And then my spouse, Sean, who I've tormented for 20 years, and he's here as well.
Where would Sean be at?
He's hiding in the back.
Sean will be there, okay.
Yeah, so.
Since you have tormented your brother for 40 years?
40 years.
40.
He's 2 years younger.
40 years. I'm going to make the assumption that your brother's going to come out during the opposition. I'm just kidding.
He will only be beat by my husband.
Okay, very good. So with that, Ms. Kent,
Yes.
thank you very much for introducing your loved ones, obviously your husband, your brother, as well as his wife, and your mother. I apologize, I did not put you in the corner. I just want you to know that back over there. So why don't we do a short introduction of yourself, and then we'll go to Q&As.
Sure. Well, thank you very much. First, Senator Pro Tem and members, it is a real distinct honor to be here. This job, without a doubt, is going to be the best job I'm ever going to have in my entire life. I have worked this department now for the 3rd time. What brought me to the department the first time is what brought me back for this last session and job, in that the people are compelling to me. The mission is compelling. The challenges are extremely large and complex. Every day is different, and so when this opportunity came, it was without a second's hesitation that I, put my hat in the ring and said, this is something that I really feel compelled to do, just for the reasons of how we serve people in California, the treatment that we offer them, the way that we conduct our business as government. It's all something that is just very important to me. So with that, I find, pleasure every day in coming to the office. I love the people that I work with. I like the people that I work for. And so with that, I will stop and say, again, deeply humbled and great honor to be here.
Well, thank you very much, Ms. Kent, and we do, I think, collectively thank you for your dedication to public service. I know this is your second run with regards to governors, then Governor Arnold Schwarzenegger, and now today, Governor Jerry Brown. So we do thank you very much for your commitment to public service, especially being the Director of Department of Healthcare Services, which is a very important agency here in California. It's a tough job. By no stretch of the imagination is it easy here in California. We're going to go straight to the members, and we're going to start off with a Q&A. I'm going to start towards my right and ask Senator Holly Mitchell if you'd like to begin your questions.
Appreciate that very much, Mr. Pro Tem, and again, welcome to our new member and Vice Chair of the committee. Good afternoon.
Hello.
I'm going to try not to take too long, Mr. Cannella. Mr. Cannella puts a hook down here when I go on too long. So I want to just kind of give you the highlight of the areas that I want to touch on.
Okay.
Just to give you a sense. I want to talk a little bit about the culture of the department. I want to talk a little bit about dental. I'd like to talk about MCO tax briefly. Would like to talk about Medi-Cal expansion to new service populations, primarily coverage for all children. And we might touch also on health disparities. And I'm also sharing those topics so my colleagues know if there's any redundancy. Give me a signal if it's something you'd prefer to talk about, and I will move on. From my perspective, Ms. Kent, just given my own professional background, what I did as a staffer in this institution, what I spent most of my professional career on, I am clear that you are leading, from my perspective, one of the most important departments in this state, quite frankly, making sure that, according to some estimates, 1/3 of all of our state residents, and many of the most vulnerable of them, have access to critical healthcare services. That is an awesome task and responsibility. And I think sometimes the culture of the department, i.e. its rather rigid bureaucracy, is perceived as, instead of meeting the needs of that very needy, at-risk, vulnerable community population, that they have not been flexible enough or focused enough to meet that core need. I have, for many years, had some concerns about the way the department communicates with your beneficiaries in writing, cultural competency, all those kinds of things. And from my perspective, leadership and culture shift really begins at the top of an organization. How would you respond to someone like me who's expressed some of those kind of, perhaps vague, but overarching cultural concerns with a State Department that really is the bridge between life and death and whether or not Californians can thrive?
I think it's a great question, and probably when you come into an organization like ours, which is so large and so complicated, and you have federal rules and financing streams, and it's not just Medi-Cal, by the way. I mean, we have lots of other programs, and so Medi-Cal is certainly the largest piece of the overall department, but that in and of itself is a challenge to also include other staff and programs without having that take off from their needs and desires. I think the department, and I've sat on both sides, I've been in the department communicating out, and I've been outside communicating in, and so I see it maybe in a way that you would, which is sometimes when you're a stakeholder and you try to communicate with the department, you will get feedback in, and then what comes out looks nothing like what you put in, and you wonder what happened in that magic box of translation.
Right.
I think we have done a lot of work, and I'm not saying that it is by any stretch of the imagination finished, but we've had a huge effort to professionalize our stakeholder engagement across all the different ways that we communicate with stakeholders. We have large groups and small groups and technical groups, and we have statutorily created bodies that advise us. We have ad hoc bodies that advise us. And I think what we've really tried to do is both professionalize the agenda. People see the agenda ahead of time. They have materials provided in advance. We post them, we share them. If we give minutes afterwards, we have follow-up items. So it's our best effort to try to let people know that a decision was made. And this is one of my personal issues, is if a decision was made that was not what was recommended by the stakeholders, it's up to us to communicate why and how that was achieved. Sometimes it's as simple as it's a financing issue, and so it's not possible from a financing perspective. Sometimes it's legal, which violates federal Medicaid law, and so it's up to us to say why, which reduces the frustration. I think from the culture of the department internally to the employees, when I came in, at the beginning of the year last year, when you think about all the work that had been done in 2011, 2012, 2013 to get ready for what happened in 2014, in some ways, it's actually amazing that the department was that we still had people that wanted to come because it was so hard and stressful. And so part of my goal stepping in was rebuilding both from a morale standpoint, as well as helping people understand the vision of what we strive for overall. I talk to employees in different levels of the department, and they may or may not fully appreciate how they fit into the overall strategy, and so they feel disconnected. Like, I sit all day and I do this job, but I don't understand how I play into the larger role. And so that has been a really consistent effort on my part, which is, it's not just the top managers, but it's mid-level, lower-level managers and line staff, understanding that you may work in third-party liability, you may work in legal, you may work in Medi-Cal eligibility, you may work in financing, but overall, what you collectively do is serve 13 million people. You do it really well under really difficult circumstances, and we have a quality strategy. So there's a lot of things that I think are in place that I'm both proud to be a part of, but also proud to be the leader of in terms of helping people internally serve those that we have responsibility for.
I appreciate, as the leader of an organization of that size and magnitude, your connection and understanding that all the members of your team have to figure out and understand and value the role they play in the bigger picture. So I appreciate that. Going from kind of culture to, in that context, what are your top concerns and priorities? Really, in not only overseeing Medi-Cal, as you said, there are a number of smaller health programs that you run, as well as the fact that you are a leader and a manager of thousands of employees. So in that overall context of both service provider and employer, if you will, what are your top priorities?
So when I came in, I had three big goals. One was improve relationships. If Medi-Cal as a program has a continuum of service delivery, improving the relationships on the front end with the counties in terms of, we have approximately 50,000 county eligibility workers that are doing our work every single day in terms of these 13 million people did not show up in the program without their efforts. And so we needed to improve the process and relationship with the counties in terms of the system, as you well know, was not great. And so we're maturing an IT system, which takes time and effort and patience, but there has been a real dedication on my part to working in partnership with the counties, helping to kind of triage some of the eligibility issues that we continue to have. Because again, people that are eligible should be in the program, and we owe, both, ourselves and those individuals every service right that they can, and it's also in a cultural and linguistic, area that we need to be really sensitive, and so I've been really mindful of that. On the back end, the process and the business that we have with the plans, we have not always been the best business partners as a department, and so simple things like contracts and rates and communication about, hey, we're adding a benefit to your portfolio and you need to do that. I mean, some of those things we have asked of the plans, and they have had to really scramble to deliver that. And so putting consistency and business processes on the back end as well, because again, if you're mindful of the fact that the beneficiary is the reason that we do all of this, they need to have a quality product that is delivered to them consistently no matter what county they're in, and that is both from an eligibility standpoint as well as a care standpoint. And so those have been a couple of my key goals. And then the people internal to the department is probably my third big goal in terms of providing leadership opportunities to develop new leaders, to providing training opportunities to improve the quality of our staff, to provide management growth. And essentially, we want to train them in-house so that they stay. And that leads to the overall stability of the department. So that's important to me as well.
Because I know that, and I guess it's to be expected to some degree given the size of the department, but you've had some turnover, you have some high vacancy in certain areas. And I know there's an expectation around succession planning, as you talked about in your Rules Committee responses. And so is succession planning a part of that process as well?
We have one, yes. And then we not only have a succession plan, but we have several things that are both internal to our department and unique, but also we have something called the DHS Leadership Academy that is funded through the foundations. We put mid-level managers through about a 9-month training course that is Medicaid broadly, as well as putting them into different policy areas, so they are taking on projects and learning about things that are outside of their expertise and program. And so those all, to me, help contribute to what we see as a important part of the succession plan, which is identifying people at lower staff levels that, you know, want to learn, want to grow, want more responsibility, and we want those people to stay. And so, you know, our vacancy rate, I think, I think we have about 230 vacancies by the time, I think, when we gave the report to Senate Rules, but we struggle in the areas that other state departments struggle most in, right? Clinical staff is really difficult. It's a little hard to find an actuary to come and work in a state department, but by and large, we are pretty good about trying to recruit and bring people in because of the importance of making sure that we have enough people doing the work and not having so much staff burnout, which is important.
Very briefly, if I may, Mr. Pro Tem, let me go to Dental Cal. And I'm going to try, even though it's hard, recognizing that you are the director, and from my perspective as a leader, your primary job is to have the right people in the right seats on the bus and to make sure that you are motivating the people who do the work to do the work and do it well. And so, you know, I think we have a tendency as legislators to want to drill down to the issues we're hearing about in Budget Committee and Policy Committee from our constituents. So I'm going to try to stay up at the 10,000-foot level. I think it's fair to say, in short, that Dental Cal historically has been what the kids say is a hot mess. Fair statement?
I would say that the kids are not far off.
Okay. And I am clear that it has been a priority of yours.
Yes.
For the last 11 months that you've been there. And when I say hot mess, it's in the context of less than half of the children enrolled in Dental Cal receive access to basic dental care. We know the provider reimbursement rates for Dental Cal providers is 30% of commercial rates. The requirements are perceived as time-consuming, burdensome, textbook definition of hot mess. If you can kind of tell us where you are, I know that there is something called Dental Transformation Incentive, which I have no idea what that means, but that's a part of the new Medi-Cal 2020 waiver. I'm assuming that is getting us to a better place. But tell us kind of what you've done and what you see on the horizon for this state to have a Dental Cal program that is accessible and of high quality.
Sure. So you're right. When I started this job, I think day 2 or day 3, I was testifying in front of one of the legislative committees on Dental Cal. So I got a
Health
pretty
Committee, I was there.
Yeah, I got a pretty clear line on that. So there's a couple of things. We have put in some new leadership. Speaking of leadership changes, we have a woman that is now leading our dental division who we have great faith and full support.
And that position had been vacant for
a long time. There had been an acting, and so securing this individual's commitment to come and work with us was really great, and she has been excellent ever since. I think that has been critical. Part of it is we put in data. So I'm not what I would say is a data geek, but I do like to have data to make decisions because that seems to be important. And so we have created a pediatric dental dashboard. So part of what we committed to doing in the dental audit was if you can't measure it, then you don't know if you're making it better or worse. And so we have outcomes that we're actually measuring and tracking to. So our utilization has gone up. In the utilization for children, so we're above 50%, but not obviously stopping and saying that that's good enough. I think part of the other issues is we've worked really hard with our vendor which is Delta Dental. They administer all of our claims for us to help identify dentists to come in. So in certain counties where we have low or no dental providers at all, we have either deployed mobile vans or we have reached out to providers and said, would you like to come in? Internally, we have looked with Delta as to the application itself in terms of we've heard from providers, I don't like rates and I don't like the paperwork and the burden. And so we said, okay, can we do something about the administration of the application and the paperwork? There's certain things about our application that we have to ask back to federal law, so we can't get around those. But we have been in discussions with Delta about using their network and using their providers to proxy. So if they want to be a DentalCal provider, could we just ask those questions that we have to on a federal level and let the credential of Delta stand in for the
Carry
rest?
the rest.
So that's in discussion. It's sometimes harder to do right away than you would like. We did outreach to families, so children under a certain age, we did mailings out to them saying dental is actually a benefit, and some people didn't even know it was a benefit. So we saw an increase in numbers with that. We have a dental locator on our website that's in partnership with some of the children's advocate groups that helps identify providers in their area that are open and accepting patients. I think one of the critical pieces was the restoration of the AB 97 cuts that was done as a part of the budget last year in partnership with the legislature. So that has been done. The money has been approved by CMS, and so we're paying those claims at a higher level now. And then, among other things, you have the dental transformation amount in the waiver. It's $750 million over 5 years. This was a critical piece to us when we were negotiating with CMS in the fall. Essentially what it says is for 5 years, and it's about $150 million per year, we have money to incentivize dental providers to either increase their DentaCal caseload or to take DentaCal for the first time. So there's direct incentive payments to providers for that. There are direct payment incentives to providers to what we would create as a dental home. So some providers that establish relationships with patients and see them on a regular, ongoing, continuing basis will get incentive payments around that. So that's creating a continuity of care and an actual provider-patient relationship. And then the last one is around dental caries prevention funding and having providers paid for that kind of prevention work. So we're really excited. I think that there's a lot of stuff that have been done to the program. I think that now that we have some of the metrics in place and some of the people in place, and we have a new state dental director that is also helpful to us from a policy and kind of guidance line. I feel better about the program today than I did the day I started, but I wouldn't say that it's settled by any stretch of the imagination, but I think we're in progress, and I feel good about that.
And because it's a part of the Medi-Cal 2020 waiver, does that mean that this program would only be in effect through 2020, or what does that mean?
So it means that the funding, the $750 million in the waiver is tied to the waiver. So it's only for 5 years. And there are specific conditions that are in the special terms and conditions under the federal guidance that we have to meet certain metrics. And I don't know the offhand if we have penalties associated with if we don't meet the metrics, we don't get the money, but that has been an ongoing issue with CMS, is that they've started to put some of those penalties in, which is if you don't hit a waiver metric, you don't get the financing, but I don't know that we have those in place for dental, but for now it's a 5-year program.
Got it. I'm going to hit on just 3 more major subjects. MCO tax. In your view, what critical programs are at risk if the legislature fails to reach an agreement on the MCO tax?
So I think the first and most visible program is the direct linkage of the passage of the MCO tax to the coordinated care initiative. So this is the demonstration that we, along with 11 other states, are doing to identify who are the most frail, elderly, or disabled individuals known as dual eligibles. So they're eligible for both Medicare and Medicaid. And we are putting them into a single managed care plan and having that plan manage both their Medicare benefits and their Medicaid benefits. When the legislature approved that initiative a few years ago, the financing around that and concerns about the costs accruing to the state were directly tied to the MCO tax. And so there's a fiscal calculation and there's statute that's involved that says if at the end of the year when the director of finance does it and looks at the CCI costs and looks at the MCO tax, if all of that doesn't net out to positive savings for the state, the program shall be terminated. So that is probably one of the most notable programs that's important and based on the passage of the MCO. I think if you remove $1 billion in general fund from the Medi-Cal program, it gets, there's only 3 things in Medi-Cal that you can really affect. So populations, benefits, and rates. It's a 3-legged stool. So if I have to cut $1 billion of general fund, which then means you lose the federal matching funds, you have to dig pretty deep, and we have done that in years past, and it's, you know, it's optional benefits, it's rates, it's optional populations. Those are the places that you get, and unfortunately, because we're so big, you usually have to cut pretty deep in order to get to $1 billion.
Right.
So-
Right. And not to mention the loss of the federal dollars. It would be devastating.
And you lose the matching funds, and in some cases, depending on who the people are, they have better matching ratios, so our CHIP children get a 65-35
Higher,
match, and so,
others.
right.
Right. That's a sobering reality. Thank you. Medi-Cal coverage for all children. Could you give us a quick update on the implementation of the expansion? When do you plan to begin enrolling children? And specifically, I think, and critically, what's your outreach plan? Because it's a new population.
Right.
Who will be serviced. I think we often fall short in the accuracy of our estimates when we ramp up a new program. I've been around long enough to remember Healthy Families Days, and we were convinced that all children eligible would enroll in the first 90 days. Not so much. Covered California, it takes effort when you are targeting a population that has never received this benefit before. So what's the outreach plan to make sure all children now benefit?
Sure. So we have a couple of stages on this. So for children today, we have about 140,000 children that are what we say known to us through Emergency Medi-Cal. So these are individuals that otherwise for their documentation status would be full scope Medi-Cal, but they're not. And so those children are in the MEDS database, and we know that they are there. And so part of our plan for the implementation of this new population starting on May 1st, or once we get the system certified to make sure that it can switch over, those people would be basically just turned over from limited aid codes to full scope aid codes. And so that's the easy
That's the cream on
population.
the top,
And
right.
that's the big part of the population. So that's
Okay.
about 140,000.
Okay.
I think we have, by what we understand from the county coverage initiatives and some other plans that provide care to these individuals through their foundation coverage support, 75 to 80,000 of those children are then now known. The foundations have been working closely with both the child advocates, us, and those coverage initiatives to do specific outreach in culturally appropriate, linguistically appropriate communications, letting them know that this benefit's going to be available, that they can enroll in Emergency Medi-Cal and have a switch earlier, or if they want to apply on May 1st, they can apply, go through the eligibility, and then do a planned process. So a lot of those communications and outreach efforts are in full process right now, with the foundations putting up a lot of financial support, technical support. There's a lot of community linkages, and so that right now has been what we have been working on. And then obviously we have the need to translate all the official notices and the welcome letter and things like that into our threshold languages, and so that's what we're in process for doing. So there's a lot of different, and again, back to your stakeholder comment earlier, is we have a lot of engagement with entities that this is very important, both the foundations that are helping support this effort as well as community-based organizations, and we're sharing documents and notices and things like that.
I just have to say on that note that I continue to be surprised every year in either health committee or in the budget context, given how old the Donnelly-Alatorre Act is, that there continues to be introduction of legislation, and we continue to hear from advocates about aspects of the communication that aren't translated into the threshold languages. You would think in 2016, California, we would even be beyond the threshold languages, considering the number we know
Yeah.
of languages that are spoken in the state. So I certainly hope with this experience, with this new program, that we do all that we are supposed to make sure that the outreach materials and every document that parent is going to need to help make sure their children get full scope Medi-Cal is made available, because we have a vested interest in it as a legislature, making sure that this program is a success.